Hello, everybody, and welcome to this incredible panel where we're going to be talking about a renewed imperative galvanizing feminist engagement to transform COVID-19 health sector responses. My name is Khalila MBOWE, and I'll be your host for today. We have an incredible panel of frontline people who've been in the research space on the front line, working to really build a health sector that truly transforms how we look at, female involvement going forward. Um, I just want to thank all the partners that have come on board to make this happen. This is the University of the Western Cape, UNU-IIGH, the Government of Mexico, DAWN, RESURJ, BBC Media Action, WHO, UN Women, and members of the Gender Equality Working Group of the SDG3 GAP. Now, one of the things that we know is while the pandemic has led to a watershed moment crystallizing injustices and systemic gender discrimination faced by marginalized women and girls, boys and men, and other gender identities, very little of this has changed mainstream health policies. We have been seeing issues in the health sector that have primarily affected women in the space as well as youth. However, not much research has been made public or has been made transparent with regards to what's really going on, as well as we haven't had enough people really raising their voices to make sure that the responses or the frontline responses with regards to COVID-19 are truly connected to making sure that we're building a space that women and youth can have their voices heard. So what we're going to be talking about today is really what are the action steps? What needs to be done to make sure that we have this engagement for our frontline workers, that we have more women in the decision-making seats, that we have more women and youth actually driving policy change in the spaces. So the fact of the matter is that to date, over 4,000 participants from primarily low middle-income countries have shaped a research protocol, thematic reports, and questions posed for a particular gender and COVID research agenda setting process that was convened. And today we're going to be hearing a little bit more about that, but then we're going to be opening up the platform as well as a conversation for more people to be engaged, and for people who want to know more and to really engage in this conversation going forward, we're going to be opening and presenting ways that you can do that. Now, the speakers for today, we have incredible lineup and women who have really done great things in this space. We have Chantal UMUHOZA, who has 15 years experience working on sexual and reproductive justice, gender equality, and socioeconomic justices through research, advocacy, policy development, and movement building. She is a member of RESURJ, and she will be speaking to us today, truly sharing her story as well as answering questions and inspiring us to think about ways forward. We also have Dr. Sabine Ortel Pregone. I'm pretty sure I have butchered your name, so you will correct me when you come on. And Dr. Sabine is a physician specialized in internal medicine, public health, and sex and gender-sensitive medicine, and an organizational consultant. She holds the chair for gender in primary and transmural care at Radboud University in Netherlands. You will also come through and correct that for me. And also on our panel, we have Dr. Natalia KANEM. Dr. Natalia KANEM is the United Nations Undersecretary General and Executive Director of the United Nations Population Fund, UNFPA, the UN Sexual and Reproductive Health Agency. Dr. KANEM has more than 30 years of strategic leadership experience in the fields of preventative medicine, public and reproductive health, social justice, and philanthropy. One of the things that you'll be able to do today is engage by asking questions in the chat tab you'll have on the side. You'll also get to comment as well as answer polls. Right now, we're going to start with our first poll for the day. This is going to be a very engaging conversation, so please do engage by asking questions, commenting, as well as answering the poll, and probably sharing your takeaways on social media as well. Our first question today is going to appear on the poll section. It should be on the right side of your screen. And our question is, Women represent only 24% of members of the 334 national COVID-19 committees around the world. You get to answer yes or no, or true or false. So the poll question will be on the side. I won't reread it again. But as you can see, we have a lot to get through in a very short time. So I will literally be driving this session to make sure that we get as much information going as possible. Do answer the poll question and engage with it once more. The poll question is: women represent only 24% of members. Women represent only 24% of members of the 334 national COVID-19 committees around the world. True or false? Please engage by answering the poll now. We will proceed once the poll questions come. Poll responses come. I will see them and be able to read them out so we all know what you all think. Just to move forward, we are entering now into a space where I'd love to welcome our speakers for the day to just let us know what it has been like building this space, and what are the gendered fault lines in the space, and then how do we truly identify and erase the gendered fault lines in the health sector. And to start us off, I'm going to invite Ms. Chantal UMUHOZA, who is a member of RESURJ from Rwanda. She shall be telling us, she should be speaking about the pandemic responses with regards to a question I'm going to pose right now. I'm just trying to see if the poll questions have been answered, if I have a response here. Not yet. So Ms. Chantal, I will just proceed with you and probably share the poll responses later. Ms. Chantal UMUHOZA, karibu sana. You're very welcome. Now over to you in 5 minutes. Could you please tell us and speak to this? The pandemic has shown us yet again where power lies within the health sector, and also shown us has also deeply highlighted how, despite all the work that has been done so far to get us here, in 2021, women and youth voices are still not included in decision-making spaces in the health sector. Could you talk to us about the lessons learned from feminist organizations and grassroots women participation in the health policy dialogues with decision makers, and how we can make sure that engagement and representation, meaningful engagement and representation, is governance going forward?
Thank you so much for having me. So much to talk about in a very small time. So I just want to say that I'm speaking from the position of a feminist from the African continent, and also taking into consideration the global South realities of feminists, but feminist organizing and issues that feminists in general have been highlighting in response to addressing health and response to the COVID-19 in general. So I really want to start this by saying we are starting from an unleveled ground when it comes to inequalities that we're talking about in the health sector in different aspects, not only inequalities between people and individuals and gender inequalities, but also inequalities between states. So issues around geopolitical power inequalities also have a role to play in how countries have been able to respond to the pandemic. There has been an equal impact of, for example, some measures like lockdown. So for some of the countries, for example, from the global South and from Africa, we cannot afford to deal with one pandemic at a time. We have to deal with this in some context in addition to other pre-existing crises like conflicts, hunger, inequalities due to economic justice, and all these issues that already remain unaddressed. So we already have these issues going on, and therefore we need to also recognize that the level is not, the ground we're starting from is not leveled, and we need to take this into consideration. We have conflicts, we also have impact of climate change that in addition to these different states have been dealing with. So these have been pre-existing, of course, because of different histories. Colonialism, part of that, but also ongoing issues that are already happening in different countries. Condition of funding and the burden of debt, for example. So when we come to inequalities between people, that has also been pre-existing. In general, We have been talking about gender inequalities, how the pandemic has really impacted mostly women and girls in different ways. So this already existed, and we've been talking about the role of unpaid care work that remains unaddressed, and how that also impacted healthcare workers, majority of whom are women. So these issues need to be addressed because we need to build in a way that is conscious of the ground that we are operating, but also we need to transform in a way that challenges these power inequalities, but also the exclusion of different identities, for example, female sex workers, LGBTQI communities that remain not addressed or seen in the health sector. The other issue I want to talk about is how the definition of health has been narrowed down when we came to the pandemic. You know, access to food is health, access to decent housing is health, access and protection from gender-based violence is health. Having access to mental health is health. So we cannot only talk about dealing with containing the virus, but also ignore other aspects of health. So in countries where these have not been addressed for centuries, they have turned on the approach of criminalization and punishing, which has made even the impact worse for different communities. So using police and criminalization as a way to enforce measures has been a response. But what I'm recommending is that we actually need to understand and marry health and social protection as one, because without the other, we cannot even be able to contain the pandemic. So this is a feminist issue. My last point is on women leadership. So women leadership is great and has to be promoted. However, women leadership is operating right now in the patriarchal system and institutions. So even in countries where we have a big number of women in leadership in parliament, it has not been enough because the COVID task force were not reflective of that. The COVID task force contained, for example, police institutions, people from the health sector, majority of whom are men. So when we're talking about a health response, I'm calling for transforming all other institutions, not just ticking the boxes of having women in parliament, because in all institutions, be it the health sector and other sector, the education sector, we need to ensure that when we talk about gender equality, we actually mean it, and we have to transform these institutions at all levels so that we mean what we have in the laws, what we have in the constitution about the principles of gender equality. So this is what I can say for now. Otherwise, I'm going to keep engaging. Thank you so much.
Thank you so much, Ms. UMUHOZA. One of the things that stood out for me is we cannot just talk about treating the virus and ignore all other aspects of health, because they have a intertwined relationship. So we have to think about how we are balancing all different aspects of health with regards to women. Next, I'm going to move on to Dr. Sabine. Dr. Sabine, please talk to us about what your work has been so far. And primarily, my question is this. Some things that are very clear right now are the differences between men's and women's immune system. And yet there still exists a bias in the research and development of new drugs, medical tools, and treatment protocols. So much so that women are negatively affected, since there is a lacking consideration to our unique makeup, which has led to severe COVID-related complications and death in women. The other day, I saw a lot of conversation about excessive bleeding for women after getting the COVID shot. Could you talk to us about how this sex bias in the medical science and R&D space, including COVID-19 therapeutics and diagnostics, and what must be done to change it?
Okay, well, thank you very much for the question and for the opportunity to speak here today. Well, I've been working in this field for quite some time, and usually the case we need to make to our colleagues, to other researchers and practitioners and clinicians is, well, please consider sex and gender differences when you look at topics in health, at topics in care, because it is important. And most of the time, well, we get nodding responses at best, and the execution is sometimes questionable, and sometimes it happens. In this case, I thought, given all the media coverage we're seeing, the fact that there is a lot of talk in all kinds of media worldwide about an increased mortality in men, a compared to women. Infection rates are not really being addressed that much, but even if they are, it was talked about the fact that women are more frequently represented as healthcare workers, so they might have a higher risk of infection, especially initially. So the whole discourse about the fact that sex and gender could impact this disease has been there, has been present quite prominently and quite surprisingly to people working in my field. So what we assumed is this should translate into action in the field of research and care. The problem is that historically, women's bodies, first of all, were not even conceived to be real or existent or an entity, so the biological differences were not even seen as real. We had one body and it was male. The next step we took was realizing that, well, there might be differences between different bodies, but what then happened is women were historically excluded from clinical trials because we wanted to protect their potential children if they were pregnant when they participated in a trial. So we excluded all women from clinical trials for a while. And then we realized, well, this might not be the best course of action. And now women are being included. And when we see that in the COVID trials, in many cases, we have a relatively good balance of women and men being included. But the information that we could gather from this is simply not divided into different groups. So we don't know. So basically what happened here is women went from being unconceivable to being invisible to now being aggregated and being lumped together in one big chunk. So we specifically looked at COVID trials because we said, well, this is a new disease. Everybody's talking about the fact that sex and gender could have an impact. We should possibly see that in the studies that are being done. So we looked at, in the beginning, at 2,000 trials that were registered at the time. We updated that now. We looked at more than 4,000 trials, and we checked, do the ones that record them, because when you do a clinical trial, you have to register it, do the ones registered explicitly say that they will look at sex and or gender differences or when they recruit people, and do they want to consider that in the analysis? And unfortunately enough, about 1 in 5 of these trials specifically said, okay, we will look at sex and gender and consider that in the recruitment, so in the access to the trial, if you want, in who is actually being studied. And unfortunately, only about 1 in 20 trials specifies that they will be looking in their analysis specifically at differences and will make these available for us all to study and to incorporate in the work we do. So what we're seeing is that although our media discourse is becoming really open about this, and we all kind of know this, it does not automatically translate. And this is probably the best forum today to talk about this because the knowledge is there, and next week we will actually publish our data, and so you can all use them, and please do, to make a case for the fact that having something talked about does not automatically lead to change, and we will need to engage much more with our institutions and in the policy-making process to actually make sure that we do have this disaggregated data that we need to make the best health choices for everyone.
Thank you so much, Dr. Sabine. I mean, so having something talked about does not necessarily mean that it will be worked on. It does not necessarily translate to change. We have a lot of work to do. Dr. Natalia KANEM, Executive Director, UNFPA, I am coming to you. And I'd like to know, on the front line of the pandemic, we have witnessed the sacrifices and service of women home carers and health workers fueling the response on ground. Also witnessed is that though women fill up the front line and hence are most at risk, shockingly, very few are involved in writing up policies and making the decisions that actually affect the health sector. What did COVID-19 show us about how we value care work and health providers? And specifically, how is this coming out in the global COVID vaccine deployment? Are we doing enough to protect our health workers and address their concerns? If not, what then needs to be done?
Well, thank you so much, dear moderator. And I would also like to thank you, Chantal. I believe that you've really laid out and connected the dots as to when we're talking about feminist transformation, we're not talking about tinkering around the edges. The
Yeah.
pandemic has indeed cast a spotlight on how much our societies depend on caregivers. And who are these caregivers? Whether you're taking care of a child, an older parent, or a patient, very likely you are female. And yet that care work too long has been invisible. And I'd like to thank Dr. Sabine because she talked about invisibility. So one of the aspects of invisibility is being underpaid or unpaid altogether or underfunded, as so many women's organizations are underfunded. Before I address your question directly, I would like to observe that since the days of Methuselah, women's bodies have been in contention. Is a woman's body her own? Of course, the answer is yes. But when we understand that many women cannot make simple decisions about their right to say no to sex, their ability to have a child or not, and too many women are subjected to practices against their will. Bringing us now to a discussion of clinicians, nurses, midwives, and uh, over 70% of whom are female. Yet when you look at who the administrators are and who the decision makers are, that percentage flips, right? So I would say that when you have a dedicated, selfless cadre of women who are putting their lives on the line every day during a pandemic, the question of life-saving vaccines becomes even more urgent. Women are facing daily exposure to this virus, COVID-19, in very close, intimate quarters. You're a nurse handling your patient. And many of them did not even have proper personal protective equipment, PPE, when we started. And UNFPA, WHO, and so many others advocated to make sure that we protect the people who are protecting us. We've made it a priority to respond to the virus by acknowledging weaknesses in the health systems, right? The system has to work for women. It should not be an afterthought, and it should be built in. Now, let me just tell you about a midwife who works with UNFPA in Afghanistan. This woman told us that she is scared of corona. Yet and still, she has a higher calling to support pregnant women in their time of need. And she said, you know, I had to overcome my fears, but she also needs help as a frontline responder in that country. And she's just one example of countless millions. She's following all the protective measures to protect herself, but she worries when she gets home about transmitting virus to the family. This is an example of a midwife who's the backbone of a health system, and that support should be mutual. We're witnessing this global vaccine deployment, which is the biggest ever in history. But again, referring to Chantal's remarks, the disparities in terms of how, as a public health system, we've not figured out how to reach the most vulnerable first and how to have equitable distribution across countries is part of the COVAX initiative and the reason for the urgency for that type of international solidarity around vaccines. And just to abbreviate, I could say a lot more about the global action plan that the United Nations and others have tried to put into place. The global action plans also have to have a feminist perspective, putting that adolescent girl at the center. Time and again, evidence has shown us that is where value to society resides. So investing in the education, in the well-being, and in the health of an adolescent girl. It's not just for her, it's for her family, her future family if she decides to have children. And I would also hasten to add that when you invest in an adolescent girl, you're transforming a society where gender-based violence has also been a feature of COVID, distressingly. and she will understand my body is my own and her full worth. Thank you so much.
Thank you so much, Dr. Natalia. There's so much here. And what we're learning even before I read the poll results is that these issues do not operate in silos. If we're talking about addressing the gender fault lines in the health sector, we have to look at it in its entirety. It's part of an entire system. So as we're talking about solutions or even identifying the challenges, we have to look at everything from a systems lens. I'm trying to see the responses from the poll that we shared in the beginning. Unfortunately, it's not very clear to me what the responses are. The writing is quite blurred, so I can't read it. With that, I will proceed with the session. Hopefully, I'll be able to see what it says as we proceed. All right, everybody. Again, so much to speak about, so much to go through. As we proceed, I'm going to invite the next presentation for the day. Speaking about these things needs a lot of galvanized support, and we have somebody from the creative sector speaking to us about the collective. I would love to welcome a presentation, a video from an incredible poet, producer, and songwriter, Q from Malawi. Born and raised in the Longwe, Cabanizo, aka Q, speaks to us about the power of the collective. As we have seen, this is a big challenge. It needs all of us together. Cue video. There is no sound to the video yet. I would just like to request somebody from the technical team to fix the sound on the video. Able to hear Q's presentation. A hand of applause. It was an incredible poem. For the interest of the speakers who could not hear the poem, Q's words and his poem, they help us drill into the important concept of oneness. So he's really talking about our common humanity and how our present and our future are intertwined. He's talking about the challenges that we're speaking about right now and how they cannot be solved if we and approach them individually, and how the power of the collective is needed to push through. In Africa, we have a concept called Ubuntu, and I am because you are, meaning we are all connected. And more to what the pandemic has woken many of us to is that an individual's well-being is caught up in the well-being of others. And the call to action that Q posed to all of us in the poem was, let's journey together. So everybody who is on the call, this is a call to all of you, from speakers to the audience. Let's journey together in curiosity. Let's journey together right now in the next session of this presentation to ask questions, share reflections on how we can truly move forward an agenda that will bring about collective transformation for this and the next generation. What we've heard is that the health sector does not operate in a silo. It's connected to so many other socioeconomic factors. And so as we're speaking about this, we have to think about it with that particular lens. So please do share your questions in the chats. I will receive them and share them with the speakers. As we wait for your questions, I'm going to start posing some questions to the speakers. Let me see, I've got a prompt here about questions. So there is a question on data for you, Sabine. Every day, older women worldwide do around 4 hours of unpaid care and domestic work. What needs to be done to make older women significant and crucial, but uncounted, unpaid care work for their families, communities, and economies visible?
Well, I'm not the only one trying to work on making data visible, and I would really highlight all my colleagues working especially in this space and trying to make the amount of unpaid work visible and counted, because it affects everything that we do. It affects our health, and we have seen in this pandemic that even when things shift, the unpaid work doesn't become less, it becomes more, and it doesn't become counted. So the point here is we really need to highlight this much more and possibly include it much more in the data we produce in my realm and the realm of academia, or in the realm of policymaking institutions that collect statutory data. So what we do now in many cases is we don't report it separately. We don't make it visible. It's a bit of the same discussion I had before about making response to pharmaceuticals visible, and so disaggregate this data and let us see. And I think here what we can contribute, and I say that from my perspective, of course, is to provide much more information on this, to make it visible and possibly analyze its impact separately, so that everybody who's out there in the field, who's out there in society, who actually has the opportunity to make this visible from outside and put pressure on organizations, has this information and can use it. So this is what we can contribute to this. On the other hand, of course, in all our presentations and in all our discussions, we should possibly pick that up more as well, so that, yes, as I said before, talking about it is not enough, but not talking about it is even less. So we need both. We need to make it visible while addressing it, and then we need to provide the data so that we can pressure organizations and change the way we're doing things.
Incredible. Thank you for that answer. I just want to ask, I think it was a really loaded question. I'm wondering if, Sabine, there's another question posed for you, but I'd love to open it up and ask if either Ms. UMUHOZA or Dr. KANEM, if you would like to also respond to that question with regards to how we can make it visible. I'd love to see if we can also touch on the differences with the visibility of such information or such conversations with regards to how we look at the global South and the global North. Such conversations they're not necessarily seen as relevant in the context of, you know, the African woman or the African caregiver. It's almost seen as taboo to speak about it, and hence even getting to a space where you can have a safe space to have these conversations might be difficult. How then can we do that same thing with regards to visibility and having these conversations truly take center stage when we're addressing such issues?
Yes, well, I'm happy to chime in on this point. It's a very important point about data and visibility. UNFPA is the United Nations Sexual and Reproductive Health Agency. It's the population fund, and we advise on census. So just as a quick example, again, since time immemorial, this phrase head of household, which we use during census enumeration, comes loaded with a mental image of who is the head of a household, of a family. And the very way that we construct our questions can mislead if we don't accurately assess the true experience of women. So data has to be collected with an intention. And the question of visibility and invisibility is very, very relevant if you're living with a disability, as 1 in 9 human beings on the planet does. If you're blind, if you're deaf, if you're physically able differently, are your needs being asked in census data questions? So as we give guidance to governments on how to construct the questions, we all have to be alerted to that serious reality. Now, on the question of data of who makes decisions, who leads, all of this is important in terms of equality of pay. Generation equality is a generation of young people that are not talking about making things, ameliorating a bad situation. We are talking about a feminist transformation. And here again, I think when you collect data, you've got to disaggregate it by gender, by race and ethnicity. We've seen how race and racism play out during the COVID pandemic, and it's been ugly. If you're a person of African descent, if you're an indigenous, if you're a member of a group of indigenous peoples, your statistics on COVID have been horrendous. So ultimately, I believe that we need a much more sophisticated epidemiology that knows to ask the right question and that listens to what it is that the data are telling us. So I thought that was really quite an astute question. Thank you.
Thank you so much, Dr. Kanem. That's a lot to think about, and I love the fact that you brought in people with who are able differently, because that's also an area that we primarily don't touch on. It's also siloed. Um, and Chantal, I'm going to proceed to you with regards to just building off what has already been shared right now. There's a question that came through from the audience with regards to the health sector and the feminist approach. Whose responsibility is it to make the health sector feminist and to really push these conversations forward? I think you're muted.
Sorry about that. Thank you so much. I mean, whose responsibility is it to transform the health sector? I mean, it's everybody. Like I said, actually like how the structure of this conversation is, it's not only about laws and institutions, it's also about science, it's also about how we structure like decision making and implementation. It's everything. It's institutions, but it's also people, and it's everything that we know that really shapes the narrative of what health is. Like in my presentation, like I was saying, we tend to think that health, in some context, it's when somebody has the disease and they're about to die. But if you look at the definition of health by the World Health Organization, it's not the mere absence of diseases. It's also the physical, the mental, and the social well-being. So when it comes to some aspects like mental health and social well-being, which are really part of health, in some contexts, those are still privileges to even access them. Mental health is still stigmatized and not accessible at all from the context where I come from and global south in general. So it is everyone's responsibility. Having the discussions like we're having it's key. Having people on board from the science sector and from decision-making power, like the UN institution, is really key as well. To continuously together change the narrative about what we think health is in a way that is grounded in human rights, is grounded in feminist principles of equality, of justice, of dignity for everybody, because everyone, whether you're in Africa, whether you're in Asia, everywhere you are, everybody deserves a dignified well-being, and it's everyone's responsibility, not just the state, to really ensure that we can do that. So it's just to continuously not only talk but act on it.
Thank you so much, Chantal. Thank you so much to all our incredible speakers and to you, the audience, who have been engaging in the polls as well as asking questions. We are around that time that we have to wrap up the session. We had a bit of a shaky start with the tech there, but we are making it through just as women do. Just to wrap up some of the things that we've talked about. We've talked about the fact that we have to connect the dots. The health sector does not operate in a silo. We have to apply systems lens in how we approach the issues and make sure that there is a gendered approach. We cannot just remain speaking about the issues. We have to figure out ways to have actual call to actions and actionable steps, not only on the policy level, but the challenge here is bringing it all the way down to institutional level, whether you're in the private sector, whether you are a healthcare worker, whether you are a person that is simply interested in these conversations, working as a movement builder, working in CSO, and so on and so forth. Because why? All these issues are connected. Making sure that we keep issues of women and youth voices being heard in the health sector is imperative, not simply for women and girls, but for the society and community as a whole. This entirely talks about how we progress as a whole human race. Now, as we're closing off for now, unfortunately, I cannot see the poll results, but I'm going to challenge us to think a certain way, to feel a certain way, and to do something. We cannot just leave here excited and empowered and reached with the conversation, but let's think about what are we going to do to truly change, right? So one, in terms of what you need to be thinking about, I'd like to challenge you to think about what a feminist COVID response should look like. What can you do? What can you inspire the people around you to do? And then what can we achieve together? Because as we have been told, it matters to us individually. It's not just something for the scientists, for people working in the international INGO level. This matters to each and every single one of us, whether you're a child, whether you're a parent, and so forth. What do we want you to feel? Feel outraged. The fact of the matter that in 2021, we're still talking about such deeply etched gender fault lines. The fact that the statistics right now are still screaming the fact that there is still so much to be done. We have a lot of, like Dr. Sabine said, the media has really highlighted some of the issues that are going on. But however, when you pull back the covers, you realize that there is still too much to be done, that we're not necessarily truly moving. So we need to push for visibility. We need to push for transparency such that we can truly be making informed decisions and making informed action steps. What do we want to do? Collectively demand for visibility. Demand visibility for change. Hashtag decade of visibility, hashtag better COVID science, hashtag vaccine equality, hashtag equal representation. It is everybody's responsibility. So what should the concrete next steps look like? What can you do right now? Join the UNU Gender and Health Hub online community at Gender Health Hub. That's where you can start. Two, participate in our gender and COVID-19 research agenda setting survey. It is right there and you can see it. Three, read out guidance notes and checklists for tackling gender-related behavior to equitable COVID-19 vaccine deployment. And then recently launched also read the recently launched BMJ podcast on papers on women, health, and gender inequalities. Be informed. Do not be apathetic. It needs all of us to individually play our part. I just want to give a final thank you to all our incredible speakers, Ms. UMUHOZA, Dr. Kanem, Dr. Sabine. Thank you for your time. Thank you for your work. Thank you for your generosity in making sure that all of us are informed and plugged in. To everybody who is here and to all the organizers, a big thank you as well. My name is Khalila MBOWE from Unleashed Africa Social Ventures here in Tanzania, and it has been an honor to journey with you together. Let's keep journeying together and keep building for generations to come. Hashtag Generation Equality, Decade of Visibility.